Most common structure that people are looking for aesthetic procedure is the breast lah. Okay. In fact, breast work is actually number 2 in Brazil. Okay. And in South America, other South America country also is still number 2, right? In US is actually I think number 2 as well. It's just that in here, in this side of the world, is actually we are actually more towards upper part, not at the lower part. Alright, so everybody knows that breast is actually a modified sweat gland. You are talking about gland structure, accumulated in certain capsule that is actually a group of the sweat gland. So it lies in subcutaneous tissue, in the superficial fascia, and then it's between 2nd and 4th rib, and then your nipple areolar complex supposed to be at your 4th intercostal space. And then you got a prolongation to the lateral side where you actually call that axillary tail of Spencer's. And then on the sections you got this is the axillary tails of the breast, and then this is the breast tissue in the capsule, which is not that obvious. You need to have very good experience to actually identify that, because there is actually a so-called distinct difference between the subcutaneous fat and then the fat, the tubular structure of the breast. Right? And then they actually lies on the pectoral muscle, and then the projections of the breast supposed to be nipple areola at the center there, and then you got this smooth curve inframammary fold towards the knee, and then the nipple areolar complex, and on top also superior pole also supposed to be convex towards your upper chest. Okay, if you go and that side, it's actually a lobule of the gland, right? Separated by the septae, and then a group of sweat gland, and then it drains into your nipple. And then it actually been whole. The hole is actually been whole by just a suspensory ligament. The problem with the suspensory ligament is a very weak fibrous tissue, and then their spring back structure or function is very similar to your any other septate, which is actually having a function of suspension, like your facial fat. I had said earlier on, it's really similar. Arterial supply is actually from all around. Okay, you got on top there, you got a thoracoacromium, thoracic branch of thoracoacromium. You got intercostal, lateral intercostal. You got medial intercostal from internal mammary, where you got a perforator in every single intercostal space. And then all this vessel is actually form the anastomosis network. Okay, so that's why in terms of the breast reductions, you can actually take out anywhere, and then they actually interconnecting in between this surrounding vessel I said earlier on. Alright. Diagrammatically, the blood supply. So you got from lateral thoracic, you got thoracoacromium, you got internal mammary, perforator. It's actually all come up together, and then anastomosis between themselves up to your nipple areolar complex. And nipple areolar complex is actually having a bit of more and a rich anastomosis, and then connected inside. Okay, so that's why nipple areolar complex you can actually cut as you wish to actually get the desirable shape, but they actually survive. In fact, when you can actually, when you're talking about circumareolar breast implant, you can even cut almost 2/3 of it, and still they actually survive. Venous is actually following the artery to the axillary, intercostal, as well as vertebral. The posterior lateral thoracic goes into your vertebra. And that's the reason why breast cancer, among the most common metastasis is to your spine. Right? Okay, lymphatic, 75% is actually ipsilateral axillary nodes, mainly on the anterior group. Okay, logic lah kan? Just actually at your next to your breast is actually your anterior part of the axillary drainage. And then they actually direct drainage to supraclavicular nodes. And then there is minor pathway to open only to major channels. Right? Okay, this is how diagrammatically it's actually distributed. So mainly is on the medial atau anterior mainly, but you can actually go up to your direct to your supraauricular through your internal memory punya group. Okay, and this is follow your mainly your artery and vein. Okay, this is following the thoracoacromion. This is following the internal memory, and this follow from your lateral thoracic. Nerve supply, same follow the vasculature. One is from the lateral subcutaneous intercostal, internal memory nerve, lateral, okay, internal memory, and then superior aspect is innervated by third, fourth, or cervical plexus. Okay, so that's the reason why when you actually planning the breast reduction, so that you actually can create a pedicle or pedicle just based on either one. That you come across the inferior pedicle breast reduction, medial pedicle, lateral pedicle, that. And then this actually the sensitive part, the most sensitive part is from your next nipple areolar complex. And then mainly is actually from a lateral cutaneous branch, fourth, some to fifth intercostal space, lateral. So that's why you seldom come across people are doing resections based on the lateral, right? Okay, laterally how this appear, and then this is so-called schematic diagram of how the suspension ligament is actually holding the breast. Okay, the problem is when you are actually having this suspension ligament laxity, then you are actually having the ptotic breast. And then, like I said earlier on, it has to be the lower pole has to be above the inframammary pole, and then this nipple areolar complex has to be above this inframammary pole. Usually at the fourth intercostal space, and this is normal. When you have this lower pole lower, or this nipple areola is actually lower, then you are actually having a ptotic breast. We'll discuss later on how we classify that. Again, same. Alright, so we go to the common problems ptotic breast. When this is most common complaint when the patient comes to aesthetic clinic with regards to their breast problems. So, the true or complete ptosis, when you peel the inframammary pole, and then one finger at the level of the nipple. So you put your finger at the inframammary pole, and then you locate the nipple areolar complex where it is. Right? So that's how you actually tell that this is a ptotic breast. So gland, skin, nipple descend together, and if the nipple is that level or lower lower than inframammary pole, then this is actually a ptotic breast. And so you put a finger at the inframemory fold level, and then you see the level of the nipple-areolar complex. At the level, or level lower to it, we consider that as a ptotic breast. As long as they are actually above the inframemory fold, you can add a normal breast, or sometimes we call pseudo-ptotic breast. Okay, first degree, when you have a nipple at the level of inframammary fold above the lower contour of the breast, means that this is the, let's say, mana yang, okay, this is the one, okay. Now, that's inframammary fold. This nipple areolar complex is below the inframammary fold, bawah the inframammary fold, but still above the lower contour of the breast. Right? So that is a minor or first degree. Second degree, nipple lies below the level of inframammary fold, but still above the lower contour. Okay? So ni dah below the inframammary fold, but still above the lower contour. So that is a second degree. And the third degree, when you have both, is actually lower than inframammary fold. The implications of classify this is actually when you have a first degree, you might get away with a fat injection, fat transfer, or implant. Okay, fat stage second degree also like that, more towards implant. But the third degree, most of the time we're not going to work with the fat transfer or implant. But of course, people are saying that you have to, again, you do a multiple sessions of fat transfer, you might get away with it. The reason, I think, is because of when you do a fat transfer, that it's not just a fat transfer. We are talking about introductions of mesenchymal stem cell. So maybe you got the chance that you actually rejuvenate the skin. It's not just about the breast tissue. Alright, pseudotosis, nipple lies above the inframammary fold, and then but skin is actually very relaxed, and this is usually because of the hypoplasia secondary to loss of weight or maternity, post-maternity. You can have a partial ptosis, you can have laxity, just the skin, and then it's just because of gravity, okay? So this is pseudotosis. And minor ptosis is actually type 1 just now, first degree. Alright, so interesting about anatomy, macam-macam. Everybody now talking about anatomy.